So good morning again, everybody. I'll just start without the pointer. I think it will be okay also to do it without a pointer. And I'm going to talk about technology that is involved in ventilator and what kind of techniques are available. And I'm not going to talk about clinical studies and evidence. I think this is not the place where this has to be discussed, because for most of the technical options we have on all the new ventilators, there's no evidence. There's no evidence that all these little things that we think make ventilation better actually result in a better outcome. Anyway, let's have a look at what we have. There's a lot of things have happened since this time, when this was the first neonatal ventilator ever built in 1963. But, some things still have not changed. The general principle of most neonatal ventilators until today is still that we have a gas flow going through a wire piece, and at the end of the wire piece there is a valve that can more or less close the gas flow, so the gas flow will go to the patient, and the valve has a certain pressure that is at which it will open, so the pressure will not get too high and not higher than set by the operator. Since then, many modes have been introduced. I don't want to go over the slide. I just want to show the multitude of options that devices deliver today. Okay, looks good. Thank you.
Okay. Back.
This is the laser. Okay, so we have a flow generator here. The air goes through the tube along the patient and then to the exit valve, and the exit valve controls the pressure in the system, and when the pressure is higher in the system than in the patient, then we will get an inspiration. So this is called pressure-controlled ventilation, and has probably not much changed in the last decades. From the respirator, we need a circuit flow going past the patient, which needs to be about 2 or 3 times higher than the alveolar minute ventilation, because the patient will also be breathing on its own and thereby draw from the gas flow that is offered by the ventilator. The inspiration happens when the pressure is higher here, then we get inspiration. Expiration is the opposite. When we lower the pressure in the circuit, the patient will exhale. To adjust the settings of the ventilator, we need to be aware of 2 things. It's the pulmonary compliance, the distensibility of the lung. The compliance is defined as change in volume by change in pressure, and the elastance is a reciprocal change in pressure you need for a certain change in volume. And with a low pressure and a high compliance, you get a much higher volume than with high pressure faced with a low lung compliance. The other basic data of the lung we need is the resistance. The resistance is a pressure gradient needed to generate a certain flow. This is symbolized by the tube. We have a pressure of 20 here, for example, and 0 here, and the air goes through the tube, and the flow you get is determined by the Hagen-Poiseuille's law, which shows that resistance is pressure by flow is a big equation where the most important variable is the radius of the tube, because it goes with the forced power, which means that if you reduce the tube diameter to 1/2, the resistance will rise 16 times. So the tube diameter is very important, And therefore, it's also very important which tube you select to intubate an infant. The basic method to ventilate is pressure-limited time cycled, which has been around for decades. When we increase the pressure, then we get an inspiratory flow, which is high at the beginning and then decelerates. And this leads to a gradual increase in lung volume, which is maximum at the end of inspiration. When we decrease the pressure to the PEEP level, then we get a decelerating expiratory flow and falling lung volume. And this can go on repeatedly, and the patient will be ventilated. Here you see several breaths. Here's the pressure, the flow, and the volume. It looks like what I've shown before. We call this continuous mandatory ventilation, or CMV, where every breath of a patient is done by the machine. The patient usually has not much influence on what's going on, and the patient is best off just by tolerating this and not trying to breathe in between. When we lower the frequency, the patient can have own breath in between. We see this on this graph here. This is a machine breath. Then the patient initiates his own breath. The patient takes away air from the circuit. So we see a little pressure drop even, and the patient has an inspiratory flow, and then followed by an expiratory flow. Here's the volume of the lung during the spontaneous breath, and here is the next machine breath. And we allow this just by offering enough bias flow in the circuit, so there's air available from which the patient can inhale, and also by having a low enough frequency so there's enough time for an extra breath initiated by the patient. These ventilators can also increase the frequency, and when we get high frequency oscillatory ventilation, this is accomplished by a membrane driven by a high frequency generator moving the air. Here's the bias flow going through, and the moving air is applied to the patient. There are also other principles generating high-frequency ventilation. The Stefan uses a valve alternating between a high and a low pressure source, which is alternately connected to the patient's lung, and thereby high-frequency ventilation is being generated, and there are other techniques on the market. High-frequency ventilation is affected by a lot of damping. The inspirations are not long enough to be transmitted through the airway to the lungs, so the pressure in the alveolar range and also the lung volume are not changing very much, as opposed to the YAPs, where the flow and the pressure are changing a lot. And this pressure drop we can later demonstrate in the left-hand corner with the Stefan ventilator, where we have a lung model, and we can actually show how the pressure drops from the YAPs into the lung. So with high-frequency ventilation, we ventilate the lung at a basically almost constant pressure and volume. And this seemed to be very, very gentle to the lung. Actually, recent studies have shown that it's not more gentle on the lung than optimized conventional ventilation. Why does it actually work? High-frequency ventilation results in a lot of effects inside the airways. In the proximal airways, we have turbulence, and we have turbulent flow also in the main stem bronchi, and farther distal, we have Pendelluft effects, changing the air from one alveolus to the other, back and forth. And also we have changing velocity profiles during inspiration and expiration, and all these effects lead to a profound mixing of the fresh air outside with the CO2 enriched air inside the lung. So we get a good and efficient gas exchange even when the tidal volumes are much lower than the dead space. The CO2 elimination is proportional to the square of the tidal volume times frequency. If we want more sophisticated ventilation modes and more information from the patient, we need additional sensors, many devices of a flow sensor being inserted here between the ventilator circuit and the endotracheal tube. So we can measure the flow, we can integrate the flow to volume, and we can offer volume-controlled ventilation and synchronization with the patient's efforts by doing this. However, we have always to be aware that there is no study showing that the use of flow sensors actually has benefits for the patients. The flow sensors introduce additional dead space. This is typically about 1 milliliters. This is probably 1/3 of a 500 gram baby's tidal volume. If you take away 1/3 of the tidal volume, you get worse CO2 washout, and this may lead to higher ventilator settings to compensate for the extra dead space. And if you have higher ventilator settings, this is probably less gentle to the patient's lung. So the question, which is still unanswered, is if there is actually continuous measurement of endotracheal tube flow necessary, or if you maybe are better off using the sensor only intermittently to get information and then taking it out again. And the use of flow sensors compared with a strategy to reduce dead space and thereby minimize tidal volume has not been shown to reduce BPD. So if you have still ventilators that don't have flow sensors, you don't have to feel bad about it in the first instance. It may be possible if you use your brain to find very good settings for the baby that you are doing as well a good job as if you use a sophisticated ventilator with a lot of sensoring. There are also alternatives for the flow sensors which are dead space free. RIP bands, the Gray-Speed capsule, NAVA, which will be covered this afternoon by my colleague Peter Riemensberger, impedance measurement and even FiO2 measurement closed loop, which I cannot cover today because of time constraints. And all these methods are also useful in non-invasive ventilation, where you have a lot of leaks, which make it very difficult to use flow sensors and interpret the flow sensor readings by a machine trying to trigger a patient. So the sensor types, there are airway pressure measurement, flow measurement at the beginning of the airway. The impedance will be measuring the electrical resistance across the chest. Esophageal sensors are prone to artifacts by peristalsis, impedance by chest wall distortion. Flow sensors have dead space. They are prone to leaks and not very good at handling leaks, and also affected by secretions. The pressure capsule of Gray-Speed can be placed on the abdomen, was initially introduced by the Infrasonics company with the Infant Star, which is no longer on the market. Currently, we have the option to use this capsule with the Stefan ventilators, which we also can show later during the demonstrations. And this is sometimes tricky in terms of placement, where to place it to get a good reading, and also movement artifacts can confuse the ventilator. Here's a photo. This is a Gray-Speed capsule stuck to the patient right here on the abdomen. So when the patient inhales, the abdomen will rise, and this will increase the pressure in this little pillow here. And through a tube, this pressure increase is transmitted to the ventilator, and the ventilator can then determine that the patient is initiating a breath, and it may be a good time to synchronize it with a machine breath. These are the rib bands which are sensitive to stretch and will be stretched and generate a signal when the patient inhales and the chest expands. So how do these things work? Here's a reading of rib band readouts. This is esophageal pressure, and we see that this is a Gillespie capsule, and this is the flow. And we see that when the esophageal pressure falls, which means the diaphragm of the patient is contracting and the patient is initiating a breath, we are getting a pretty fast pressure drop, also a pressure rise in the Gillespie capsule. So it's about simultaneously, and also the rib band, they are about the same speed in determining that the patient is initiating a breath. So this seems to work pretty well. Here are the time delays between the esophageal pressure and the rib band, and this is 52 milliseconds and 10 milliseconds. These are pretty low values, and rib band on the abdomen seems to work better than the rib band attached to the chest, which is logical because when the baby inspires, the abdomen will rise every time, but the chest may not rise because the baby may have retractions, and actually the chest may lower, and then the rib band will not get as well as a good signal as if placed on the abdomen. So the abdomen seems to be a good place to determine infant breath. This is another chart comparing different sensors. We have the flow signal in yellow, the rib band, the Gillespie capsule in blue, and the respiration band is in red. And we see that the respiration sensor here has a very early pressure rise, which is actually coming a bit earlier than the inspiratory flow, which is coming here. This is the machine breath, and this is probably the patient's own effort to initiate a breath, and this is very well picked up by the respiration sensor. And all these sensors are available on different machines. This is probably one of the most sophisticated methods, the NAVA, which requires an esophageal sensor, which is on the downside because this sensor has to be placed in the esophagus, may not be comfortable for every patient, and is available in one of the ventilators and will be covered in more detail in a later talk this afternoon, so I don't have to go over this in great detail. This chart is a study trying to show that NAVA has less bad trigger events than pressure and volume triggers. So if we go back to ventilation modes, we have patient-triggered ventilation by any of the mentioned sensors. There's a trigger threshold, and when this is exceeded, the machine will initiate breath. And several different support methods are possible. Assist-controlled ventilation means that every trigger is responded by the machine by a machine breath. So the patient has control about the ventilation frequency of the machine. For the patient, it's very easy. The patient only has to exceed the trigger threshold and then will get a breath from the machine. And Here you see a longer recording of this. Here's the inspiratory flow, the tidal volume. The frequency is not quite the same. It's changing a bit depending on the patient's effort. This is esophageal pressure, and we see that the patient is getting machine breath every time the esophageal pressure decreases, so the machine has been able to pick up every breathing effort of the patient and help the patient with the inspiration. However, we can also get auto-trigger. This is again the esophageal pressure reading, and we clearly see that the patient didn't want a breath here, but anyway, he got one because some movement artifacts triggered the machine, and the infant got a breath. So this is auto-trigger, which can be fixed by increasing the trigger threshold, but then the triggering will get slower. So it's sometimes a difficult task to find the correct trigger threshold for optimal interaction. If you increase the trigger threshold too high, we get a failure of the trigger. As we see here, the patient wanted a breath but didn't get one because the trigger threshold was too high, was not exceeded by the patient's effort, and no breath was initiated. The worst occurrence is face-locking expiration. Here you can see the patient inhales, but the machine does nothing, and when the patient exhales, we get an artifact here, and the machine initiates a breath. So the machine initiates inspiration every time the patient wants to exhale, and this is like a phase shift of 180 degrees. The patient tries to inhale here and here and here, and the machine does it exactly the other way around. When the patient tries to exhale, the machine inhales. This is an interaction that has to be changed quickly because it will probably be a lot of stress for the patient and for his lung, and also may very much decrease the CO2 removal. You can also, with a triggering device, like any of the sensors I mentioned, we can do synchronized intermittent mandatory ventilation, SIMV, which is basically the same as IMV in terms of support. The patient gets some of his breath supported by the machine, but not all. The patient initiates a breath here in the middle, which is not supported. But the machine has time windows to place the machine breath in synchrony with the patient's efforts. So these breaths are applied at times when the patient tries to inhale anyway, but this is not happening on every breath of the patient. We have to use a lower machine frequency to give time for the interaction to work out. Another development is pressure support ventilation. Pressure support ventilation can be used with a flow sensor or with a Gray-Speed capsule, which means that the patient gets not only control about the start of the inspiration of the machine, but also about, regarding the end of the inspiration. So you see that the inspiratory time changes up here, which is determined by the inspiratory flow. When the inspiratory flow goes below a certain threshold, then the machine will terminate the inspiration. And if the inspiratory flow takes longer, then the inspiration of the machine takes longer. So in this, with this type of support, you don't have to set an inspiratory time on the ventilator, because the ventilator will terminate the inspiration when the patient feels that the inspiration has been long enough. And we are getting more sophisticated. Now we combine SIMV with pressure support ventilation. We have two machine breaths, and which follow the ventilator, the set ventilator pressure, but the inspiratory time. And the start of the inspiration is controlled by the patient. And here in the middle we have a breath that is partially supported by the machine, and also the start of the expiration is controlled by the patient. When you have a flow sensor, you can also use volume controlled ventilation, which means that the ventilator does not set a certain pressure, and the air that goes into the patient's lung is determined by the pulmonary compliance, but the other way around. You set a certain tidal volume you want to apply to the patient, and then the ventilator will apply as much pressure as needed to generate exactly the tidal volume that was preset. And this means that the respirator can adjust to changing pulmonary compliance. When the patient has a strong exhalation, the patient tried to cry and the tube was in place, the vocal cords couldn't close, so the patient, when trying to cry, pushed out all the air in the lung and the lung was mostly collapsed. Then we have a very much decreased compliance and increased elastance. That means the next breath is very difficult to generate a sufficient tidal volume, but the ventilator will take care of that, because the ventilator will apply the tidal volume then with a higher pressure if you use volume controlled ventilation. So people thought that volume controlled ventilation may reduce the rate of blue spells occurring in active preterm infants still on the ventilator, but studies have not been able to show that this actually happened. A combination of pressure controlled and volume controlled ventilation would be volume guaranteed ventilation, where the ventilator monitors the expiratory tidal volume of the patient by using a flow sensor. And if the tidal volume is higher than the preset value, then the ventilator will reduce the pressure for the next breath. And if the tidal volume is still high, then the ventilator will reduce the pressure again. When the patient then becomes more difficult to ventilate, the ventilator can ramp the ventilator pressure up again in order to maintain a certain tidal volume. So this is for each breath. The pressure is pre-calculated by the ventilator. It's like a pressure-controlled ventilation, but the pressure is continuously changed and adjusted to the pulmonary compliance of the patient, which has been shown in studies to end up with a lower average airway pressure than when we have not volume guarantee ventilation, but pressure controlled ventilation with the preset pressure, because the machine continuously tries to wean the patient whenever this is possible. So this seems to be a very gentle and also flexible mode of ventilation. However, you obviously need a flow sensor to do that, and the flow sensor, as I told you, may require higher ventilator settings from the beginning. Still not very common mode to give the patient full control about all aspects of his ventilation is proportional assist ventilation, where the airway pressure follows proportionally to the patient's efforts. How does the machine determine the patient's effort? The machine has preset values for compliance and resistance of the patient. And from the amount of inspired air, the ventilator can then calculate the retraction force of the lung that has to be overcome. So if the patient takes a big breath, then we have a big retraction force of the lung, and the patient will need bigger help than when the patient takes a small breath. And this you can see on this chart, the ventilator pressure and also the flow continuously change according to the patient's effort. The patient is in full control, and his own breathing is just augmented by the respirator. And the respirator only works to reduce the work of breathing for the patient, while the patient is doing his own ventilation as much as he can. However, this mode is obviously prone to apnea. If the patient stops breathing, then the ventilator would be there waiting for the next breath and not doing anything. So we need a backup ventilation that kicks in to overcome this phase of apnea, so the patient will not get bad desaturation. On this chart you can see the changing efforts during proportional assisted ventilation. You see the esophageal pressure here, which is a good measure of the patient's efforts, and when the efforts are small, the ventilator pressure being applied is small. When the patient tries to take deeper breath, then the ventilator will apply bigger breath and higher pressures to, here's the pressure, to help the patient accomplish his own ventilation. So if there's an apnea, the backup ventilation has to kick in until the patient takes over again, and then the ventilator switches back to proportional assisted ventilation. So we have a lot of patient-initiated modes available with newer machines, and made possible by the different sensors that are included in the modern ventilators. I have a comparison here, SIMV. The clinician still is setting the peak inspiratory pressure, the inspiratory time, and the frequency. The patient has only control about the timing of his ventilation. In assist control ventilation, the clinician sets peak inspiratory pressure and inspiratory time, while the patient is in control of the frequency. And in pressure support ventilation, the patient also gets control about inspiratory time. The only thing which is set by the clinician is the peak inspiratory pressure. And in proportional assisted ventilation, everything is controlled by the patient. But as we know, if you give control about things to somebody, you must have somebody you can rely on to use this control sensibly, and therefore we need a backup ventilation in case the patient is getting the control but is not using this power to control his ventilation to his own advantage. What else can ventilators do? If you have a flow sensor, you can also get information about the patient's disease, and I'm now going over a bit of some examples of what information in diagnostic terms you can get from the ventilator about your patient. Here you see reflexes that are generated by the respiratory system of the patient. This is Head's paradoxical reflex. This is the hearing-Borel reflex. The hearing-Borel reflex means that a big breath disables the patient's own efforts, and the esophageal pressure drop is much smaller because the patient feels, I have had enough tidal volume, I stop inhaling here, and this is called the hearing-Borel reflex. The opposite is the Head's paradoxical reflex, which means that there's an especially big breath generated by machine breath, and both reflexes can be observed in the unit especially when you are using synchronized modes of ventilation. We can determine the lung time constant by looking at the flow chart of the patient. This is inspiratory flow, expiratory flow. If the expiration takes much longer, then we have a much longer lung time constant. And we can determine the lung time constant by looking at the expiratory flow. And if we decrease the expiratory time too much, then we will have gas trapping, which you can also easily see on the flow curve, because the expiratory flow does not reach the zero line before the next inspiration kicks in. It should look like this, but here it looks like that. The inspiration comes too early. The patient has not fully exhaled This means we get gas trapping, we get a reduced tidal volume because the patient cannot fully exhale, and we have a much higher PEEP inside the lung than we think we have. Yeah?
About the obstruction and gas trapping, but you answered the question with the next.
Okay, great. Good. So what you also can find out with the flow sensor is leaks. Leaks are especially during inspiration. The trachea dilates and the air will flow out on either side of the endotracheal tube. And you see the leak in the flow curve by a zero line, which is above the actual zero line, and this is the leak flow during expiration. In the volume curve, if you have the volume curve on your screen, then you see the leak by a staircase effect. The inspiration here, the expiration should go back to the same volume as before, but it doesn't, it stays up here. That means the volume curve is shifting up, and this is probably a leak around the endotracheal tube. In high frequency ventilation, you can see the beginning obstruction of the airway by observing the flow curve, and when the flow curve drops, then you probably have secretions and you need to suction the baby, and this information you get by using the flow sensor. You can also measure pressure volume curves of your lung and to get more information. In the pressure volume curve, the line from A to C will determine the compliance of the lung, while D to B is the resistive loss, and thereby a measure of the airway resistance. And by measuring these things, the ventilator can determine resistance and compliance of the patient and display this on the screen. If you want it more sophisticated, you can measure pressure loops and display these on the screen and gather information about the patient from the loops. The volume pressure loop is here, and the increase from this point to this point will be the compliance. In most machines you can probably go with cursors on these points and then get a direct reading of the compliance during this exact breath. The flow pressure loop looks usually like this, and you get an almost linear shape here, and the slope of this line during expiration is a measure of airway resistance, and you can determine the resistance by measuring the slope of this line. And in the flow volume loop, you get a ramp here, and this is proportional to the time constant of the patient's lung. So what is the time constant? I will show you on a later slide. This is just another example of a pressure volume loop, and when this gets pretty flat in the upper area, you are probably over-distending the lung and should reduce the peak inspiratory pressure. So the loop looks like this and is not flattened up here. Here's another demonstration how you can use two cursors to determine pulmonary compliance in this example. So what is the time constant? The time constant is the product of resistance times compliance, and it determines how fast your lung can respond to a pressure change of the ventilator. You need about 3 time constants to get a 95% pressure equilibration. For 99%, you need at least 5 time constants, and this applies to inspiration and also to expiration. And so if you know the resistance and the compliance, you can calculate the time constant and get an idea of how inspiratory and expiratory times may optimally be set for your individual patient. And also with the third loop, I'll show it again, with the flow volume loop, you can also directly measure the time constant by measuring this slope here. So, and if you decrease the inspiratory time too much or the expiratory time too much, you will see that the tidal volume decreases, and this is because the times have been shortened too much, and this can be seen on the ventilator screen if the flow is being measured, which may alert a clinician to change the ventilator settings to more fitting values. By doing this, you can at least optimize the frequency. You can find the highest frequency which can be run with the lung you have. The lung time constant you cannot change. It's more or less built into the patient, but you can try to find the ventilator frequency that is up to that time constant, and by optimizing the frequency you can reduce the tidal volume as much as possible, and thereby achieving a ventilation which is less stressful and less injurious for the lung. Some machines also can do occlusions to measure static compliance values. This is an inspiratory occlusion. The machine closes the airway opening and then measures the pressure that builds up, and we see that the pressure is here, and with this pressure measurement you can determine the static compliance of the patient, which is more accurate than the dynamic compliance of the patient. With an expiratory occlusion, what we see here, we see a pressure drop after the occlusion, which means that the patient probably had gas trapping and you need to prolong the expiratory time. Surfactant application can be monitored by a flow sensor. Surfactant has been installed here, and we see a strong pressure drop in tidal volume. So this is caused by the surfactant fluid causing airway obstruction, and you can see it right away and then respond to it by a temporary pressure increase to maintain tidal volume during the surfactant application and prevent the patient from getting a desaturation during surfactant application. You can also do sustained inflations and monitor the effect on the ventilator display. So ventilators can ventilate the patient. They can be triggered. They can support patient's own breath. They can adjust to patient's efforts by using synchronization, by using pressure support, where you also allow the patient to determine the inspiratory time. And also you can give the patient full control in proportional assist ventilation. You can also get information about the patient's lung mechanics. You can follow lung mechanics during the stay on the ICU. You can see how the lung improves. You can see when the lung deteriorates. You can observe the effects of surfactant treatment. You can see the compliance increase after surfactant treatment by repeated measurements. All these informations you can nowadays get from your ventilator. But however, most of these features are very nice and very interesting, but they have not shown to improve outcome. Thank you for your attention.